My name is Professor Sarah Anderson and I'm the Director of ISCRR. Firstly, I'd like to acknowledge that we're meeting on the lands of the traditional owners, on the lands of which we work and live, which are the unceded lands of the Wadawurrung, Woiwurrung and Boonwurrung people of the Kulin Nation. And I'd like to pay our respects to elders past and present and emerging, and extend this acknowledgement to the traditional owners of the lands where you work and live, and to any Aboriginal and Torres Strait Islander people who are joining us here today. For those of you who are new to our webinars, ISCRR is a unique partnership between Monash University and WorkSafe Victoria. And over the past 15 years, we've had the pleasure of working with world-leading researchers in the fields of workplace health and safety. Today, we are hosting the session Pain Education, ISCRR's evaluation of WorkSafe Victoria's program. And our panel includes 3 speakers. Our first speaker, Dr. Ivana Randjelovic, who is ISCRR's Senior Research Officer and worked on the qualitative component of this evaluation. Dr. Janine McMillan is ISCRR's Research Lead and an adjunct academic in the School of Public Health and Preventative Medicine at Monash University. And Dr. Daly, FACP, who is a specialist pain physiotherapist and APA musculoskeletal physiotherapist. She is the clinical lead for pain and disability on WorkSafe Victoria's clinical panel and the clinical lead for allied health on the Transport Accident Commission's TAC's clinical panel. She's also a clinician working with people with persistent pain and training other clinicians to do the same. We also have Mark Phillips, Manager of Clinical Services at WorkSafe Victoria, who will join the panel in the QA session following the presentation. Just a little bit of housekeeping before we start. The session will be recorded and will be available to view on ISCRR's channels in the future. There's an opportunity to post questions using the Zoom Q&A function as we go, and there will be a Q&A session at the end, so we will work to get to as many of the questions as we can. I'm now going to hand over to Dr. Anne Daly.
Thanks very much for that, Sarah. So we're going to talk today about this pain education intervention that we introduced for injured workers that showed improvements in both pain and mental health outcomes and has been widely accepted by those involved. I hope that it gets bigger and bigger. I hope it widens up because you get so depressed when you're not working and you need that level of support. You just need it, and it's community as well. I think it's saving lives. When I read this quote from one of the injured workers, I was really moved. We'd been receiving positive feedback for some time, but the worker's thoughts summed up what I knew to be true as a clinician, but which we often don't hear when we're working at our desks at WorkSafe. This worker felt heard and they felt supported. So we started doing some work with titled pain physios during COVID to provide a new stream of support to workers during unprecedented times here in Victoria. But the work we're presenting today is the second generation of this work, offering the pain education sessions to injured workers at 16 to 40 weeks of their claim who were flagged as being at risk of delayed recovery and return to work. The Australian Physiotherapy Association and the Australian College of Physiotherapists have a well-established tiered system of membership with general members, titled members, and then specialist members or fellows. For this program, physiotherapists who'd been credentialed with our peak bodies for physiotherapy in Australia, because of their experience and their knowledge related to working with people with complex pain presentations, were utilised. They could provide up to 6 one-hour individualised pain education sessions with workers face-to-face, utilising telehealth or a hybrid of both. And the unique difference to other interventions was that the injured workers were allowed to continue working with their existing clinicians while participating in this intervention. So this program was adding something to their management rather than taking something away. Thank you, and I'll pass over to Ivana.
Actually, it's myself now. So I'm going to talk about the survey findings, but I'll first talk about the overview of the evaluation that ISCRR did. So at the start, before the pain intervention sessions, all injured workers that were undergoing this were asked to fill out a survey, which is called a mini EPOC. And EPOC stands for Electronic Persistent Pain Outcomes Collaboration. And then they had the pain education sessions And then they were asked to fill out three surveys again, the mini EPOC again, as well as a global rating of change scale and the patient experience questionnaire. So the actual mini EPOC itself is a validated questionnaire designed for use in niche situations and comprises short versions of other validated outcome measures, including items from the brief pain inventory, the pain health questionnaire, which includes questions on depression and anxiety, as well as items from the pain self-efficacy questionnaire, which are valid as a standalone tool. As part of the evaluation, we also did interviews. We interviewed 7 injured workers, 6 APA titled physiotherapists, 2 other treaters, both of whom were other physiotherapists, because the injured workers were allowed to continue to see their physiotherapists while they were also going through this intervention. We also interviewed 4 case managers and 3 agent managers, and Ivana will be presenting the interview findings after myself. So these are the research questions for the evaluation. The first question was, what are the thoughts and experiences of the injured workers, the APA titled physiotherapists, other treaters or other physiotherapists, case managers, and agent managers involved in the pain education program? The second question was, what aspects of the intervention work well and what could be improved? The third was, what would increase the uptake of this intervention? And the fourth, what are injured workers' pain and mental health outcomes before and after the intervention? And I'll address this fourth question now. So the key findings for the whole evaluation are summarised on this slide. So if you don't remember anything else from the whole talk, this is a good one to remember. So we found that the injured workers had reduced pain, less interference of pain on their daily activities, better sleep, better mental health, and increased self-efficacy after the pain education sessions. And in the interviews, the findings from the interviews showed that there was positive outcomes for most injured workers. There was a shift in their understanding of pain. The APA physiotherapists went above and beyond in their sessions, and the case managers appreciated the program. So I'll talk about the survey data first. And I'll start with the mini EPOC data. So the injured workers were asked to rate their pain severity from 0, which was no pain, to 10, which is pain as bad as you can imagine, to describe their pain on average in the past week. So if we start over on the right-hand side graph, there was 50 injured workers that completed the before and after survey. And we found that there was a highly statistically significant reduction in their average pain from before the pain intervention, pain education intervention, to afterwards, with a large Cohen's d effect size. And then we could also categorise the scores based on the mini EPOC scoring. So pain can be rated as either mild, where they scored 0 to 4, moderate, 5 to 6, or severe, 7 to 10. And as you can see on the left-hand side, and this just really gives a lot more richer information, I think, than just the average. As you can see that, before is the bars that are orange are before the pain education sessions, and the bars that are blue show after the whole program's finished. And for those that classified as severe, you can see that before the intervention, there was 31 people out of 50 whose average pain fell into the severe category. But afterwards, only 17 people. So there was quite a large drop in those who's rated their average pain in the past week as being severe. And then there was an increase in the moderate and the mild average pain. And then the next one was also part of the brief pain inventory, interference of pain on daily activities. Again, on the right-hand side, you can see that the influence of pain on their daily activities reduced from before to after the program. Again, it was highly statistically significant with a large effect size. And looking at the left-hand graph, again, you can see there was a drop in those that fell into the severe category. So that means Beforehand, there was 36 people who felt that the interference of their pain on their daily activities was severe, whereas afterwards it was only 26. And if you look in the mild category, there was a big increase from only 3 beforehand to 14 afterwards. And this is very similar, but for the interference of pain on sleep. Again, it's a statistically significant reduction of on the interference of pain on their sleep after the program, and also with a very large effect size. And again, on the left-hand graph, you can see that there was a reduction in those who categorised that fell into the severe category, and an increase in moderate and mild. And then the anxiety score. So in the patient health questionnaire, there was 4 PHQ-4 items. So 2 were for anxiety and 2 were for depression. And a total sum of the anxiety items on their PHQ-4 scale of 3 or more was considered positive for screening purposes. So again, there was a reduction in the number of people who were classified as anxious or had anxiety based on when we categorised them into normal and anxiety, and a reduction in the overall values. And again, that was statistically significant, but with a smaller co-D effect size. And again, a very similar pattern for depression. There was a reduction in the overall depression scores from 4 down to 3, and a reduction in those that were classified as depression compared to before the intervention, and also an increase in those who are classified as normal. And the last one out of the mini EPOC survey results was looking at the pain self-efficacy questions. So injured workers were asked 2 questions about their confidence and their ability to work and have a normal life despite the pain. So the answers range from 0, not at all confident, to 6, completely confident. And the total score was calculated as the sum of the 2 numbers. A score of less than or equal to 5 meant that the person needed help to improve confidence to perform daily activities. As you can see in this one, there was an improvement in their self-efficacy. And when it was categorised into confident and not confident, there was an increase in those from 11 before the program to 18 afterwards that were confident to really have a normal life despite their pain. Okay, if we move on to the other 2 questions that weren't part of the mini EPOC. The first one was the global rating of change scale. So the injured workers were asked, compared with before your pain education sessions, how would you describe yourself now overall? So this was actually a 7-point scale. I've only shown the results for unchanged, better, much better, and very much better, because there was actually no one that classified themselves as very much worse, or worse. So as you can see from this, out of the 40 people who answered this question, only 7 people said that their life was unchanged, and the other 82.5% all said that they were either better, much better, or very much better after the pain education program. And lastly, the injured workers were asked to fill out the patient satisfaction questionnaire. And this comprised 7 questions related to the injured worker's experience with the APA titled pain physiotherapist. The first question referred to whether or not they were really spending enough time with the APA titled physiotherapist in their sessions, and if it was meeting the injured worker's needs. The second question looked at the safety and high quality of care. The third was respect for a person, their culture and beliefs. The fourth was listening and communication. The fifth was being included in choices about one's care. The sixth was the personal privacy and health information satisfaction. And the final 7th question was the ability to comment or complain about care and having their concerns dealt with properly and promptly. And so looking at the actual graphs, the darkest colour was always, and the darker of the 2 oranges was most of the time. And so you can see right across all 7 questions, most people actually judged that they were always or most of the time very happy with, their and that they had enough time, they felt, safe and high quality, respected, listened to, included, that their privacy was respected, and they were able to comment. There was also some that said, some of the time on enough time, and there was one person who felt that they didn't quite have enough time. But on the whole, most people felt that they were, across all these categories, that they were always, respected and etc. Okay. So we're up to the interview findings now. So I'll hand over to Ivana. Thanks, Ivana.
So much, Janine. Can you please put on the next slide? Amazing. Thank you so much. So in this section, I'll discuss the interview findings, and I'll focus on several aspects of the pain education program, including what was positive about the program, what challenges participants faced, and the operational and communicational aspects of the program. So we conducted 22 semi-structured interviews via Zoom or phone. And as Janine has mentioned earlier in the presentation, we interviewed injured workers, APA title physios, other treaters, and case and agent managers. So let's look at the positive aspects of the program first. Injured workers told us that they valued the support and community they found while participating in the program, and some of them reported that it was life-saving. They also gained a better understanding of their pain, how it affects their life, and how to manage it. And they said that APA title physiotherapists went above and beyond to support their recovery. The agents reported that this program helped improve their relationship with injured workers and said that keeping other treatments while participating in pain education was very beneficial for injured workers. And APA title pain physios appreciated extended assessments. They valued the opportunity to utilize a person-centered approach, and also said that the sessions were guided by workers' needs, including education, appropriate exercises, and goal setting. So in this slide, we see the two quotes from injured workers. The first injured worker said, when they were speaking about the things that they've learned in pain education, they said there was a lot of psychological support, a lot of information about pain, the different triggers that can cause pain, how the pain can be physical, psychological, some environmental factors that contribute to the pain. It was extremely informative, and the person was very knowledgeable. And the second injured worker was describing what they learned in the pain education. And they said, she's like, try and give it a number some days so you can focus on a number. All right, maybe I'm only a 5 today. Take note, because your brain needs to be retrained, because your brain just wakes up and it goes 10, 10 straight away. And it's not always going to be a 10. It's just that your brain thinks it because it's been so long. Okay, so in this slide, we can see the quotes from an APA pain physiotherapist and a case manager. And the APA physio said, I actually liked that the content wasn't terribly dictated. It was very open, because I think that it could be patient-centered. Like, I would have felt that it would have distracted from the benefits of the worker if it was too directed to what you actually discussed. In the second quote, we can see that one of the case managers spoke about a client that they worked with, and that client was going through the pain education, and they said the following. I did definitely notice a change. I think that after she started getting the pain education, she was actually agreeable to try with the return to work, which was great. And when I have conversations with her, she was just describing to me the strategies that she had gained as well on how to cope with everything. We also collected data about about the challenges some of the participants experienced with the program. So the program was not a good fit for everyone, mostly due to the nature of the injuries. Delivering the program via telehealth was challenging for some APA physios and injured workers, especially if the nature of injuries was categorized as complex. Case managers said that they needed more support, especially around having a better understanding of the program. Injured workers and case managers said that they often couldn't distinguish between the pain education and some other similar programs. And also APA physios and other treaters said that the time needed for communication and follow-up work should be billable. We collected the data about the operational aspects of the pain education program as well. And in this context, the APA title physiotherapist reported that most of the referrals had sufficient information. However, the quality of the information varied. The agents appreciated that the referrals were organized and written by the clinical panel. The other treaters said that there was a need to streamline the referral process, including introducing online referrals. And they also said that the injured workers would benefit from additional pain education sessions and group sessions with other injured workers. And finally, the APA titled pain physio said that the outcome measures should be available in the online format. The participants we interviewed spoke about the communicational aspect of the program and the need for more information. So the injured workers told us that they learned about the program predominantly through their case managers. However, the information that the case managers shared with them really varied in quality. And in addition to this, the case managers and the other treaters said that they needed more information about the pain education program. The APA titled pain physiotherapist said that they communicated really well with WorkSafe Victoria and the agents. However, some of the agents told us that several APA physios that I worked with failed to send reports and information about the injured workers. And finally, we also found that the unbillable time affected communication between the APA pain physios and other treaters. So in this slide, we can see the quotes about the communication between the APA titled pain physios and the agents. And the first quote is from the APA physio. And they said, just being able to communicate with the case managers or the agents, it's really good. It's a bit deeper level of relationship you get through a program like this, that you can email freely, you can have conversations, you can make recommendations, and it's helpful for both sides. It's just an improved way of collaborating. On the other hand, we have a quote from one of the agents who said that they would I would love to see a more structured post-implementation, because we have 2 or 3 providers who are fantastic, and they will send us a report after 3 sessions and then again at the very end. However, we have some providers and they were not, we don't know where they're up to with the things. And just to finalize the presentation, let's look at some learnings and considerations we gained from this evaluation. So in summary, feedback from injured workers was overwhelmingly positive. There was a decrease in overall distress and pain interference with activities and sleep. APA physiotherapists appreciated longer assessments. Other physios said that patients should have early access to this treatment and that the referral process was slow. And then agents, case managers, injured workers, and other treaters needed more information about pain education sessions. And finally, let's look at some considerations. So creating consistent messaging and improving communication, allowing referrals to come from other treaters, allowing for additional billing codes for practitioners, making outcome measures easily accessible. And finally, the last consideration was to design promotional material. Thank you so much. I'll hand over to Sarah.
Thanks very much, Ivana, and thanks very much to Anne and Janine for the presentation. We've got some pre-submitted questions that came through earlier, but please feel free to add any questions into the Q&A, and we will attempt to work through them as we go through this next part of the session. So I'd like now to ask the first question to Mark, who hasn't presented but has been an active participant in this project, around what the recommendations are moving forward and if the pain education pilot will continue.
Thanks, Sarah, and thank you for the presentation, everyone, today. So The pilot program's now moved to an ongoing business mode. So that means that as it currently exists, that referral mechanisms for those workers around 16 to 40 weeks that are identified through the case conference program we have with our WorkSafe agents, they are still occurring. We've also opened it up to other avenues. The other avenues we've got currently is where a WorkSafe clinical panelist comes across a situation as part of another review. And I think that this will be beneficial, and it doesn't have to be a physiotherapy review. We've had ones from chiropractic reviews and osteopathic reviews. So that's another mechanism now that we're using. Thirdly, we've also got a WorkSafe clinical support line, which I'll put a link to in the chat. And any provider can contact that line, and out of that line, they'll get to talk to a call back from a clinical panelist. And as part of that discussion, this is identified that this program might be beneficial. Then that's another mechanism that people can utilise to talk to firstly a panelist and then identify whether these 6 sort of pain sessions would be beneficial. Yep.
Great, thanks so much, Mark. The next question sort of is linked to this, and it might be for you or Anne, which is really around, are there any plans to scale this up using non-pain specialist physios or exercise physiologists, for example?
Yeah, I'll start and might want to add something at the end. But so I guess, and Anne touched on this in the presentation, one of the strong factors that allowed us to get this up and running to start with as a pilot was the fact of the framework that the Australian Physiotherapy Association and the College of Physiotherapists have put in place around the titling of the pain physiotherapist. So that gives a sort of it's a robust process that gives us as WorkSafe some reassurance that these people have got a certain level of skills, experience above the other physiotherapists who might be treating. So there's no plans to open that up to other non-titled physiotherapists. We are open to other physiotherapists who become titled pain physiotherapists to joining the program. So certainly that's an avenue for physiotherapists to explore if they want to be part of the program. Outside physiotherapists, no plan at the moment to extend it. I think before we considered that, we would have to be confident that that discipline, whether it's exercise physiologist or another discipline, had some similar sort of equivalent framework in place to that justified that sort of the being classified as a titled or specialist sort of rate. So that's sort of where we're at the moment with that. And is any comments that you want to make about the titling pain physiotherapy program expand on what you've already said, or?
I think probably one thing I would add to this, Mark, is around the fact that sort of a separate aim of this work was that clinicians, no matter who they were, whether they're physios or GPs or osteos, chiros, EPs, have access to the APA titled pain physios who are seeing their clients as well. And so what we're trying to achieve with this pilot is also upskilling of more generalist clinicians out in the community. So there's this just increase in general knowledge around pain education. Pain education isn't necessarily the easiest thing to deliver to people, and working with people in that really sort of individual way, it's complex work. It really is. And so that's why I think, the titling process that occurs through the APA and the College of Physiotherapists is very, very robust. And it would be great to see that happening across other professions as well.
Great, thanks, Anne. The next question's for you, so don't go away. It's really around, is there a way to get key information to all workers with physical injuries at the start of a claim that might be written or online?
Yeah, sure. So I was just making a few notes about this before we started today, and I think the important things here are that in the early days of an injury, most people are going to have high expectations of good recovery. And so any messages that you wanted to deliver somewhere around that time really be nuanced towards recovery messages, and supporting that idea of hope that there will be a good recovery, but also messages that include the fact that recovery doesn't necessarily mean 100% back to, you know, where you were beforehand, unfortunately, and also messages around being back at work. Being at work is part of that recovery process rather than, you know, the final destination. I also think in that messages around helping a worker to recognise when their progress has stalled or when the treatment that they've been having is no longer as efficacious as it was, and what they could actually do for that. And what I'd really love to see are resources that develop written, virtual, that fit with all the different sorts of workers that we see coming in with injuries, that really allows us to gently uplift their health literacy and in particular their pain literacy. And also that sense of empowering them to be part of their recovery process and not just be this sort of passive recipient of it. So I think of this as sort of like an inoculation program that we could launch against the development of persistent pain by providing appropriate amounts of education across all workers coming into the scheme early on in their injury, and then just uplifting that as they go along.
Thank you. And you've sort of touched on this, but it's another question from someone, which is they were interested about how injured workers were identified as being suitable for the intervention. If you note, the target range is sort of 16 to 40 weeks, and whether Anne or anyone else thinks that earlier identification and referral could be indicated for some workers, and if so, what particulars or factors or pieces of information might allow for earlier intervention?
Yeah. So I'll certainly start off with this, and others can join in as they would like to. So again, I had some time to prepare for this before the talk, and I've looked at it in three ways. How could a claims manager recognise some of this complexity early on, and how could a clinician recognise it? And I think, you know, from the point of view of a claims management perspective, looking at, you know, has the person had previous claims? Are they taking opioid medications for more than, say, 4 weeks, particularly after a surgical intervention? Are they requesting or attending for lots of passive treatment? Or on the other hand, are they not having any treatment, which is often a sign of, you know, avoidance and fear? Conditions and claims where it's an aggravation or an exacerbation of a pre-existing condition, even when that's not compensable, those are likely to, you know, continue to sort of bubble along and need more intervention. I think also claims often are put in after the person might have had a condition building up over a number of months. So actually, by the time the claim comes in, it's already what we could classify as a persistent pain problem. Early requests for interventional pain medicine, that would be another flag that I would go, okay, well, we really need to be looking at pain education first of all. And also workers who might not be, who might not fit well into a group pain management program. And so that might be people who have, you know, specific literacy or educational issues, people from different cultures, speaking different languages, but also some people have personalities that just don't really fit with a group program. And so they're the sort of things that I think would trigger me as a case manager to think, yeah, I need to be thinking about this. I'll go on to my other points, but stop me if you want to. So there's also, when it comes to clinicians, it's not just about the patient, it's about the clinician. And we have a lot of inexperienced clinicians who are treating compensable clients. And this is not easy work for an inexperienced clinician. It can be really hard to be doing all the things you think you should be doing as a physical therapist and then adding in a pain education layer on top of that. It's that's a difficult thing for any clinician to do, but for someone who's inexperienced, that's a really tough ask. I think also clinicians often just get stuck in their rut of doing the same thing. And when things aren't improving, they can just keep doing more of the same and not realizing that there's something that could be added in. So I think there's clinician factors as well. And then from the clinical point of view with patients, again, a bit similar to the case managers, people who've got history of other pain conditions, or there's evidence of poor recovery from a previous injury. That's often a real giveaway that they're likely to have a poor recovery period again. That's often due to the physiology of their nervous system. People who present with low health literacy, pain that is excessively distressing and disabling, where you go, this is really outside of what I would expect given what I know of this condition. Poor adherence to exercise and activity strategies. And often that's not just because the person can't be bothered or is lazy. It's often, again, related to fear and avoidance. And people who are really stuck in that biological model of what's going on with me, or biomechanical, I need someone to structurally fix me. And people who can't really see that there's this whole biopsychosocial context to how they're presenting. So we can see that as clinicians in the way that person presents to us, but we can also see that by using risk measures like the Arebro short form or the WIP predict and start back tools, but also in a lack of progress on the patient reported outcome measures that we use as well. So there's lots of ways. It's a general picture. It's not like just one specific thing where you'd go, yeah, they definitely need pain education.
Thank you.
And I might just add, Sarah, I might just add to that. Sure. So I think firstly, just in those two categories that Anne talked about, certainly, so case managers, as I said, this is a program originated from some case conferences we were doing with WorkSafe, between WorkSafe and our WorkSafe agents, and that's where that 16 to 14 week range came up. But, you know, I think if any sort of case manager in the Victorian context anyway, had identified that there could be benefit earlier, then they could contact a clinical panel for consideration of it coming in earlier. I think also, I think what Anne said about providers, and particularly providers who may be less experienced and struggling in the compensation, treating in the compensation system, certainly encourage them to contact the clinical support line, and through that then they can talk to a clinical panellist and then help, and that may then be one thing that comes out of that the referral to the 6 week or the 6 session tidal pain physiotherapy program can occur. I think this reinforces again, which I know Anne mentioned earlier, I think one of the strengths of this program is that we have allowed the current treaters to stay on board and be still involved. And so for those inexperienced physiotherapists, I think it's a really great opportunity to get some really good feedback from the pain physiotherapists about some of the strategies that they may be able to apply, not maybe at the same level of skill that the tidal pain physiotherapists have got, but they can still apply to other patients in the future. And if they continue to treat that same patient, they can sort of then apply that to that same patient as well. So there's a few sort of just things I wanted to add in there about other pathways. Yeah.
And I think both of you have probably touched on this to a degree, but I think it's probably key to call out in terms of if there are any key clinical markers that could be flagged. And I know, Anne, you've talked about quite a lot of them. I'm just wondering if there's anything else from the clinical presentation perspective that would be significant for a primary treater. So for a GP or a physio to all of a sudden go, oh, maybe actually there's a problem here. Maybe some pain education would be something beneficial beyond what you've already told us, which was a lot, in a good way.
I think probably one of the big barriers that we would see in compensable healthcare is the worker being stuck in there's something structurally wrong with me. I need it to be structurally fixed, which often leads to that perception that I need surgery to fix something because it's going to, scaffold me back together. And we know that, some people do need surgery and will benefit from surgery, but having pain education instead of or before a surgical intervention means that the worker is going to be in a much better position to move forward with or without that surgery. So I think that and one of the issues is that there's a lot of clinicians who also have that very biomedical structural philosophy around injury as well. So that's probably one of the biggest flags.
Fantastic, thank you. I'm going to slip in an online one before we go back to some other ones, just to give the panel some warning. So we've had one question, which was actually around, but is there a set number of sessions in the program, or were sessions determined by the injured worker's needs?
Look, you go and go.
You can go, Mark.
So yeah, it's capped at 6 sessions. But having said that, I think it's very rare we've had people ask for more than 6 sessions. So I think one of the strengths of this program, from a broader WorkSafe clinical framework perspective, is that the quality of what's being delivered can be done within the 6 sessions. So, and sometimes there's been less sessions that are needed. We've had a very few instances where there's been a request for more, and we've looked at that on a case-by-case basis. But yeah, we've actually found that the 6 sessions is, seems to be the right number. And anything you want to add?
Yeah, just to say that this is individualized to each worker. And so we do have a checklist that when clinical panelists are involved in sort of a desktop review of the worker before these case conferences, they might go, okay, well, this is what I'm hearing when I speak to the physio or chiro or osteo, whoever. These are things I think might need to be emphasized in the pain education, but it's totally individualized. And that's the success of it. This is something that you can only present in this one-to-one way. You're matching the clinician with the worker and the information with the literacy level of that worker.
That's really helpful. A couple of quick ones before there's a couple more online ones, which was, is it possible to obtain online access?
I'm not sure if that means via telehealth or as an online program.
I think let's go with telehealth.
Yes, so we used we can use a hybrid, and that's certainly how this developed. Pain education is well delivered using telehealth, provided everybody's comfortable with that, because it's generally a hands-off process. Although it's really useful to have at least one session face-to-face, because there's usually a physical examination that occurs within this process. So yes, it can be face-to-face, it can be totally telehealth. And one of the huge benefits of that is being able to reach workers in rural and regional areas where there's very little pain facilities, and there's staff, clinicians tend to be generalists, which is exactly what they need to be, but it's very hard to be across all of these sort of areas of expertise.
Right, thank you. I'm going to combine two, just because we are getting slightly short of time, which was, one is what the first part of the question is, what are their what were the measurements of success? And the other part that I'll bring in, which is, whilst the EPOC strives to provide an objective measure for pain, it is still limited. And were there any objective measures of return to work outcomes or functional capacity that are relevant to measuring pain?
I'd probably say around the measures of success that we've spoken about those in the talk. And, in terms of, outcome measurement for this, wanted to keep in mind, this is up to 6 hours. This isn't a 80, 100-hour pain management program. This is a brief intervention, and we didn't want to overburden anybody with what we collected. And that was the choice of mini EPOC. I have a role on the advisory committee for EPOC, so we had a lot of discussion around what might be the most appropriate measures to use. I think that one of the strengths of this study is the qualitative information and the quantitative information. Actually hearing from the mouths of the people who were involved with this was really, really interesting. And I think that what we didn't measure was return to work. And so we have introduced to our outcome measurement the WPAI, which is the Work Productivity and Activity Impairments Questionnaire, which is actually part of the bigger EPOC group. So we're going to monitor that, but we're also aware that there's a lot happening for these workers. It's not just, oh, let's do pain ed and nothing else at this time. There's a lot going on. So anything we measure is a snapshot of everything that's happening at that time. But we did want to be a bit more specific around work, obviously, therefore the inclusion of the WPAI.
Great, thank you. One for you, Mark. Are there any plans to trial in any other states?
Look, not that I'm aware of. There was one other state, I think, that was exploring a bit, but I'm not quite sure where they got to, so I won't sort of mention that here today. The APA titling program is a national program, and so we have had clinicians in other states who meet the criteria deliver the program on Victorian compensation scheme workers who may now reside in another state, or in some cases maybe fit that rural category that Anne specified, and not able to do that hybrid face-to-face mode. So that's so that's where we have so other physios in other states can reach out to join our program, but they'd only be on Victorian workers. Yeah.
And the last question we've got at the moment is probably one maybe for Janine, but I'll let you guys decide who to answer, which really is around, so some of the graphs showed for mild and moderate categories, the post measures increased, whereas severe categories, the post measures reduced. Do you think this might mean that the intervention is better suited for a person with more complex injuries or more psychosocial factors that are present?
I personally think that people right across the injury spectrum and pain spectrum probably all benefited. So I think what happened is that, the people from the more severe categories might have gone to moderate, but then the moderate might have gone to mild. And, even within the, different categories, they've sort of moved down. And the statistics showed that the standard deviations, which is basically the variance, were quite small. Like it was quite tight. So I think all of them sort of probably improved. Not just, the really severe ones. So I think for any injured worker who's in pain, actually understanding the biopsychosocial influences on how they feel the pain is important. So I think it would be helpful for all injured workers.
Thank you, Janine. And for one last question, the question's really around, did the sessions include discussing the risk of pain medication?
So I although I've overseen this program, I haven't been a clinician who's delivered it myself. Issues related to scope of practice come up when we talk about medications, and so I certainly can't make any generalized comments about this. Workers certainly do ask a lot of questions about their medications, and in general, physios know that they need to be careful around scope of practice related to discussing medications, and often they will reflect back to the GP or the pain medicine specialist related to their use of medications. So it's a complex area. It's an important area. And I think one of the big things here, and we see this also in the network pain programs, is that if you want to reduce somebody's medication, take something away from them that they see as being pain reducing, even if it really isn't doing that at the same time, if you're not giving them something else, something to add into that, then it's very hard for people with, troubling pain to be able to accept that and to feel comfortable about reducing their medications to whatever is, the lowest level they can get to while being able to be active. And so part of these programs, I think the benefit of them is that, particularly if there's communication with the prescribers, then you're giving something to the person that's possibly more supportive than what the medication actually is. So it's about saying, we're not just taking it away, you're a bad person for taking that medication, but how about we work on some other strategies so medication's not the only thing that you're trying to use to cope with your pain.
Right, thanks, Anne. Well, on that note, I'd like to thank all our speakers today and all the attendees. The webinar is going to be made available to all registrants in the coming week. Once this finishes, an evaluation pop-up box will appear. If you could please share your feedback and whether you're interested in attending future sessions, it would be really helpful. We'll continue to run webinars like this one on a huge range of topics throughout the year. And if there's a topic that you think would be really interesting for us to cover, please contact us at info@iscrr, so iscrr.com.au. And again, I'd like to thank the panelists and everyone for joining us today. Thank you.